I'm from a primary care department for the last 30 years, and I work at San Francisco General and at our faculty practice, community practice. And for the last 25 years, I have been, as a psychologist, working in the area of improving behavioral management of diabetes for all the reasons you can think of. But I have to admit that in the last 10 years, I have become really aware that the behavioral management of diabetes is not enough, that somehow we are missing something. And that evoked a series of studies and investigations that I wanted to share with you. It's really a story, and I thought it might be interesting to walk you through some of those chapters in that story, give you an idea of some of the things we've learned about how behavior change works and how it doesn't work, so that you can possibly take some of these ideas and then incorporate them into your practice, or at least begin thinking about them in ways that might inform how you deal with certain patients. So that's my goal. That's what I'd like to. Good? Okay. That sounds okay. We're on the same page. And because my memory is not as good as it used to be, I actually brought notes, so I'll be able to at least know where I am. I have no conflicts of interest, no declaration. I have a number of conflicts, but not having to do with this. Okay. I don't have to tell you how difficult it is for most adult type 2 patients to manage their disease. This is not an easy disease to manage. It's continuous, there's no vacation, there's medication, there's diet and exercise, all the usual things that we think about. And there's no break. It keeps on going on, and there's always the fear that it will get worse. So it makes sense to me to think about the fact that there are many patients who are not doing so well. And here's an interesting study just to illustrate this. This is a large epidemiological study that showed that a little over 50% of patients, type 2 patients in this particular study, it's a 2013 study, actually met ADA targets for A1C. This is the ABCs, A1C, blood pressure, cholesterol. Slightly fewer met blood pressure targets, and we can agree or disagree whether ADA standards or targets are appropriate, but just in terms of the conversation, slightly fewer than a lower percentage met blood pressure targets, and lower still met cholesterol targets. The striking thing in the study was that only 18.8% of patients met all three. Okay? So this is a reflection of something we all know, that there are a bunch of patients who aren't really doing very well. Now, we all have patients like this. They're doing reasonably well with their glucose control. They come back regularly, and when problems arise, we can, address problems. We can make some behavioral changes. We make some referrals. They come back. They've met their goals. We've done some action planning. They're generally doing okay. Now, show of hands. How many of you have patients who are not doing well with their diabetes, who when they, who when they come back, you're doing with them what you've been doing with them over and over and over, okay? You set up problem-solving situations with them. You set up action plans. You make the referrals for diabetes education. You do all the things that you can think of following this general behavioral model to help them. And these are the ones we're most worried about. Pull your hair out with some of these folks. And there's an incredible amount of tension, I know, in me in working with them because I can't get this thing rolling with them. How many? Look around the room. Does this surprise anybody? We're all in this kettle of soup together. So, let me just go on to the next, whoops. This is the group I want to talk about. It's not your whole patient panel with diabetes. It's the subgroup that we have all this difficulty with. And one of the reasons we have difficulty is that behavior ain't easy to change. Habits are hard to change. It takes time and energy to make the changes. We often don't know what else we need to do that we haven't done already with these patients. Life gets in the way, and for healthcare providers, it was interesting. I bumped into a colleague of mine in our faculty practice when we were talking about a patient around, trying to get some things going with this patient, and she said, I just don't have enough time. And I asked her an interesting question because it hadn't dawned on me until she raised it. I said, let's say you had an hour with this patient this week, next week, and the following week. What would you do differently? And that's what I got. Let's pause. Nothing. We do very much of what we have already been doing, right? But we'd have more time to do it. Now, it may be having more time to do the same things that we failed in the past would make it kind of better, and we wouldn't be failing, or they wouldn't be failing. I hate to use the word failing, but you know what I mean. They would do much better. But we end up doing the same things over and over and over again. We are, in many ways, spinning our wheels. And for these patients, the costs are exceedingly high. There's increased risk of complications, just as we were talking about, more frequent healthcare visits, which involves increased costs to the system, hospitalizations, emergency room visits, general higher healthcare costs, but also increased pain and suffering, incredibly increased pain and suffering. So several years ago, this whole process really instilled on us an idea of stepping back and taking a look at what we do. What is our logic model? How do we approach this? How do we think about it? We wanted to look at this more freshly. So what we did is we spent a whole mess of time thinking through the process we go through to institute change in these patients. And let me walk you through what we ended up with. The ultimate goal for all of us until they find a complete cure for type 2 diabetes, which isn't going to be tomorrow afternoon, the real goal is to help patients with type 2 diabetes live a long and healthy life with their disease. That's our goal, and frankly, that's their goal. And to reach that goal, probably there's a huge amount of literature out there and research that suggests that probably the best way to do that is to help patients reach their diabetes numbers. And these are the ABCs. Yes, there's some variation about the effects long-term in terms of mortality, as we've been talking about. But overall, our clinical strategy is get these folks A1Cs, blood pressure, lipid levels within reasonable target levels that probably need to be personalized rather than just coming up with some abstract target figure. But that makes sense. The next step in the logic model was, okay, if that's the goal, how do we get them from where they are now for this group of patients, this really difficult group of patients? How do we get them from where they are now to where we want them to be? Well, actions. Now, assuming that they have the correct medications at the correct dosage, the trick is to get them to take it. And to get them to take it in the way the medications are prescribed. This involves a whole range of behavior change, right? You have diet, general lifestyle, alcohol, smoking, stress management. We can keep going on and on and on. Very complicated list of behavior changes that's required. And this is where the whole logic sequence falls apart. How do we get these patients to take these particular actions? Well, let's look at our behavioral toolbox and see how we generally go about doing it. The first thing we have in our behavioral toolbox is diabetes education. How many of you are diabetes educators? Bunch of you. Oh, good. Okay. Well, there's little question that diabetes education is crucial in our toolbox. If patients don't know about their disease, they don't know what it's about, they don't know how their actions can affect their disease, it doesn't make sense. So they need diabetes education. Getting there is another matter, but we won't go into that. The second thing we give them in our behavioral toolbox are a series of tools. We teach them how to monitor their blood glucose where it's appropriate. We give them behavioral monitoring tools so that when we ask them to change behavior, they can actually monitor that change over time. We hook them up with a bunch of how-tos, like, okay, if you need to go on a diet, here's portion size, monitoring your carbohydrate consumption, all this kind of stuff. We teach them vehicles for actually engaging in that process. We link them to community resources to facilitate and support those activities, and then we use our big gun behavioral intervention types: action planning, goal setting, reviewing obstacles, right? This is the stuff we do normally. And then we build into our EHRs reminders and ticklers so that we can then contact, right? We can contact these people to find out how they're doing. That's our big gun tool. How well does it work for these patients? Well, it turns out there is a huge amount of literature that evaluates that question. Here's a study that's prototypic, and I've selected it because it's easy to describe. This is a group headed by Dr. DeWald, a 2009 publication. And what she did, what her group did, was to get a whole bunch of folks with type 2 diabetes who were having some difficulty. And what she did is sit them down individually and work with them individually by giving them diabetes education, very appropriate, personalized, tailored education, and then setting up a series of action plans, behavioral monitoring procedures, the usual kinds of things we do when we want to help people change their behavior. And then they evaluated the effect of this intervention compared to controls at 2 weeks, 4 weeks, and 12 weeks. Now take a gander at the column that's outlined in blue. This is the column of a percent of individuals who achieved the goal that's labeled in the action plan and then sustained the behavior over time. And that sustaining of behavior over time is crucial. By the way, we are great in helping people lose weight. We're really good at it. We're really lousy in helping them sustain the weight loss. So it's not just the behavior change we need to look at, it's sustaining that behavior change over time. Now here's what she found. At 2 weeks, 71% of the patients in this part of the trial achieved the goal and sustained the behavior over 2 weeks. Now 71% is pretty good. Yeah, but what happened to the other percent? That's a substantial chunk of folks. At 4 weeks, it dropped to 66%. At 12 weeks, down to 59%. And here's the kicker. Only 33% of the entire sample, 33% of the entire sample attained their goal and sustained it over time. So in a lot of ways, what we have found is that although our behavioral toolbox is essential and probably necessary for the facilitation of behavior change in these patients, it's not sufficient for a large number of patients with diabetes. It's not enough. And so the question is, what's the missing variable? What's the missing context here? What do we need to be focusing on that we're not focusing on for this subgroup of patients that we all have, where we're having a great deal of difficulty? And the idea behind this is that these patients must have some very, very good, powerful reasons for not going along what we've been asking them to do. That sounds kind of silly. These are intelligent people. These are very bright people, some of them. Why wouldn't they do the very thing that will help them remain healthy? Anybody ever think of that? It doesn't make any sense. Well, we wondered that. And so we decided to initiate a series of very high-tech rocket science studies. What we did is we asked them, why wouldn't you do this stuff? But we did it in a very research-oriented way. This is one of the studies. There were several of them. We gathered together 40 adults, poorly controlled, and we mixed them by gender, ethnicity, age, and duration of diabetes. And we sat them down with a running tape recorder, and we asked them in a very structured way, but with a lot of give and take, a series of questions that built up to the biggie, which is the last question. What is it like living with diabetes? How do you think and feel about diabetes? What happens to you as a person as you take care of your diabetes, or don't, as the case may be? And this is the biggie. What stops you from doing what your healthcare provider asks you to do and what you may know you need to do to take care of your diabetes? And that's the crucial question. Why aren't you doing what we know you need to do? Because these people know, by and large. They may not know all the details, but they have a sense of it. What we ended up with after a series of pretty complicated qualitative analyses that were really quite interesting to go through. We had 40 hours of audio tape to go through, and they were transcribed, and we went through all the processes. And this was just one of several studies that we did in the same frame. Is we identified 5 general, very good reasons why people don't take care of themselves and their diabetes. Mental health challenges, discouraging results, environmental influences, expectations, and social influences. Now, these are not independent. They kind of overlap. Now, what I'd like to do, because I think this is such an important area, is to walk you through what we learned in this study, because it tells us something about why people don't do what we think they should do, and why we get into this. Us pushing, trying to get them to do it, and by their passivity often, them pushing back, and nothing gets done. And we spin our wheels, and time goes on. So let's walk through, I'll do this quickly, just to give you a flavor of some of the very good reasons why our patients don't follow through with what we suggest. Now, we all know that mental health challenges are high, mental health disorders are high in this population. And here you see depression, substance abuse, eating disorders, anxiety disorders. How many of you think that the prevalence of psychiatric disorders in this population is high? I have news for you. It is no higher than in the standard population. The reason we know that is we've studied a bunch of patients, several thousand, and not only have we, but if you look at a paper that Anne was a co-author on that came out in Diabetes Care, the prevalence of depression, current depression in 6,700 type 1 patients, 4%. Do you know what the prevalence of depression is in the population? CDC data is 4%. The distinction is these folks, yes, they're distressed, they're upset, they've got lots of reasons, but are they clinically diagnosable? Do they meet major criteria for mental health disorders of the kinds we're talking about? No, those are the rates. And by the way, there's an error here. Anxiety disorders is not 3%, it's 1.5%. I have to correct that. Discouraging result. So mental health disorders, some folks do have mental health disorders, and when they have them, they need to be diagnosed and treated, but it only accounts for a small percentage of the population that we're working with, and it doesn't account much for why we're having trouble with them managing their disease. Discouraging results. People report the fact that they work around weight loss, and they see very insignificant changes. They see little change in changes in A1C once they're doing all kinds of stuff over the past years. Remember, they didn't just get diagnosed yesterday. Most of these folks have had this disease for a considerable period of time. They take new medications and find their side effects, or they take new medications and they don't feel anything, nothing really changes, and they don't see any change in their blood sugars. So there's no perceived value for engaging in the very thing we're asking them to do. Environmental issue. By the way, diabetes is expensive. Anybody ever tell you that? Regardless of the supports we provide, it is expensive to have this disease and manage it well. And most patients have work and financial stresses that involve competing priorities, family and finances. How many of you work with Hispanic families who are really struggling to make ends meet? And family comes first, especially for women with young children. The money goes to feed them, and getting their diet is secondary. It just doesn't happen. So there's all kinds of conflicting cultural preferences and influences, helping Asian Americans reduce rice consumption, reducing carbohydrate consumption in Hispanic families, all these kinds of things, incredibly complicated issues of safety for exercise in certain communities and availability of healthy food. Listen to this list of very good reasons why people don't go ahead and take care of themselves the way we think they should. It's a long list. The fascinating thing for a psychologist was the report of many people about their personal expectations. I need to be perfect. I had a patient a couple of weeks ago who we finally got going on a 3-day-a-week, 10-minute per day exercise, walking. Took a while. She came back, she stopped. Why? Why did you stop? Well, if I should do it in 3, think how much better it would be if I did it in 7. And if it was only 10 minutes, think how good it would be if it was 30 minutes. So that's what she did. 7 days a week, 30 minutes a day. She did it for 5 days. She missed a day and she said, that's it, I'm done. I need to be perfect. Either I'm perfect or nothing. I should be better by this now. I've had this disease for years and years and years. I should know how to manage this better. It shouldn't be so difficult. The stuff they're telling me to do never worked before. Why should it work now? Can I trust my healthcare provider? The issue of trust is enormous, especially among adults aged 20 to 35 who are so disengaged with the healthcare system. But we've been telling these folks to do stuff for a long time. Has it worked for them? No. Now, they're having some contributions into this, but they don't trust us. You've told me this before. I tried it. It doesn't work, or I can't do it. My poor A1C will be my fault. So if I try something and it doesn't have an effect, another failure. It'll never be enough. I mean, these are actual verbatim responses we got from these folks. If I start this now, I can never take a break. How many of you have had that statement made by someone just starting insulin? If I start insulin now, I will never, ever be able to stop insulin. I'm doomed. There's a message of feeling doomed about this. And then the biggie. I did it to myself anyway. They've been telling me for years I was at risk, and I didn't take care of myself, and my family blames me, and they're right, I should be blamed. Social influences, this overlaps a bit. Nobody really understands in my family. I have to take care of my family first. I mentioned that earlier. Others nag me about my diabetes. I don't want to deal with them, the diabetes police. Many of you heard Bill Plonsky talk about that. My family blames me just like I blame myself. I don't want to stand out, because if I do stand out as having diabetes, people will think less of me, because everybody knows I caused it myself. And it'll be embarrassing to start something and fail again. So these are the 5 very good reasons for not following through. Mental health challenges, discouraging results, environmental influences, expectations, and social influences. These reasons are understandable if you get into the mindset of these individuals, and they are to be expected. There's nothing wacky or off the wall about any of these things. So what we did with all of these data, and it was a good hunk of data, what we did with these data is to dig deeply and try to identify some underlying themes, some cross-cutting measures that we could think about that we might be able to use to translate into something we could do in clinical care. We were wanting to translate all these data into something that would be tied into a clinical kind of modality. So we went into these data in much more detail, and we made an interesting discovery. What we found was, for all of these reasons, they all shared 3 things in common. One, they were of long duration. These attitudes, beliefs, and whatevers had existed for a long time. It wasn't something that happened yesterday. Second, it had to do with the context of their lives, how they were, where they were, family, the community. It had to do a lot with that. And most importantly, every one of them had an emotional component. It was related to the feelings, beliefs, and expectations around diabetes and its management. And so what we did is to call them common feeling scenarios. The underlying cross-current of of the very good reasons people have for not doing what we have asked them to do. Let me walk through just a small number of these common feeling scenarios as a way of pulling them together. A feeling of hopelessness, demoralization, and being overwhelmed with this disease. They've struggled with it for this is not depression. Hopelessness is not depression. It can be a characteristic, but the way I'm talking about it, it is not depression. It's very realistic. They've tried and tried and tried. It doesn't work for them. Regardless of the reason, that's how they experience. And they're overwhelmed with this disease and demoralized about what the future will hold. And it scares the dickens out of them, because they know down the line the risk of complications are staring them in the face, and their family members know, and the usual comment you get from a spouse or family member is, if you keep doing this and you get sick, I got to take care of you. And that's the message you get, and it gets fed back to them. They're angry, they're frightened, they're ashamed and embarrassed because they feel they brought it on themselves. And again, highly distrustful of the healthcare system for not finding ways to help them, because everything that they've tried hasn't worked. Some things have, and yes, things have changed in some ways, but this disease is still not under control. Highly self-critical, they blame themselves, and they feel quite guilty about it. So what we began to realize was that the critical missing link in our logic model were diabetes feelings, the emotional side of diabetes, wrapped up into diabetes-related expectations and diabetes-related beliefs. That was the missing component. And this became very interesting for me as a psychologist, because what I began to realize, if we jump ahead into behavior without dealing with the feelings, beliefs, and expectations that drive that behavior, we might as well be working with one arm behind our back. These feelings and expectations and beliefs put the brakes on behavior change. And what's fascinating about this is we rarely pay attention to this, and yet it's extraordinarily powerful. We tried to come up with a name for this, because you have to have a name for everything, and we didn't want to come up with another acronym because we've got so many of them around anyway. So we called it diabetes distress, a broad term to encompass the diabetes-related feelings, beliefs, and expectations around their disease. What's the definition? It refers to the expected worries, concerns, fears, and threats that are associated with struggling with a demanding and progressive chronic disease, its management, threats of complications, loss of functioning. Expected is the crucial word. This is part of everybody's experience with diabetes, some more, some less, and it will vary over time, especially around the emergence of a complication, around a new medication. It ebbs and flows over time. It's not static. Diabetes distress reflects a broad range of affective experience. You've seen some of those feeling scenarios, and the list goes on and on and on. So it's not just a couple of symptoms. This is a broad range of experience. And we call them common feeling scenarios as a way of kind of describing them. They are anchored, these feelings. They're anchored in diabetes. Unlike depression, like the PHQ, how many of you use the PHQ? Okay, lots of folks use, it's a 9-item scale to screen for depressive symptoms. It doesn't diagnose clinical depression, but it gives you an idea of the severity of depression symptoms. That's unrelated to anything, by the way. When you fill out the PHQ, it doesn't ask you what caused your depressive symptom. It just says, do you have it? Whereas diabetes distress not only ranks severity, but it asks you, well, about what? What are you distressed about? So it's linked to context and source. It tells you something about process, and if you know what caused it, you have a vehicle for intervening around it. It's viewed as an expected response to a health threat. It does not imply psychopathology. It's not a comorbid disorder or a condition. It's part and parcel of having diabetes. So when we meet with patients with diabetes, we will check all kinds of things on their profile, on their blood profiles, and we'll also check their levels of distress. Why? Because distress drives behavior. If we eliminate and don't look at that part of the picture, we've basically missed probably one of the most powerful tools we have for instigating and helping folks maintain change. The only problem is, when you go around the country, as I have and talk to folks about it, many patients and most healthcare providers are unaware of the emotions underlying diabetes distress. It's not part of our usual conversation with patients. And so what we decided to do in the next chapter in this little saga that I'm sharing with you is that we decided, since we had a name, we knew pretty much what comprised it, we wanted to come up with a scale that would enable us to scale patients on their level of distress and identify potential sources. Because then we can have a conversation with these patients about what's going on and hopefully find ways of at least dealing with it. And so we took verbatim phrases from the transcripts that we had developed from these interviews with these patients, and we came up with a whole mess of items, and we administered a whole mess of people. I won't go through all the details, but we ended up with a total of a 17-item scale, and the scale is called, for some absurd reason, the Diabetes Distress Scale, the DDS. And it's comprised, as I said, of 17 items broken down into 4 general areas of distress: regimen distress, maintaining stress around maintaining a good regimen, interpersonal distress, obtaining disease-related emotional support. Whoops, related, kind of slipped the line there. Emotional burden, managing the emotional demands of diabetes, and a big one that popped out unexpectedly, the distress they have around obtaining good health care over time. A big area of distress. The prevalence of distress was surprisingly high. Among type 2 adults, over 500 in our particular study. I like to say over 500. It's kind of a grand statement. It's actually 503, but it's over 500. Current levels of distress, 35%, and we just finished a study that Anne's involved in with 386 type 1s. It was 39%. Over 18 months, the prevalence of distress in our type 2 population was 65%. That's over 3 in 5 patients you see over an 18-month period have clinically meaningful diabetes distress. So what's this distress stuff related to? Well, I'm a clinical researcher. Good question. Do a study. So we did a study. So what I'm going to do is share with you the relationship between diabetes distress and a couple of other things, but you'll notice there's a column on the right-hand side. Not only did we measure distress and a bunch of other stuff, but we also included the PHQ-9 and a classical structured psychiatric interview, highly reliable for the diagnosis of DSM-5 psychiatric disorders called the SCID. And I never remember what I've been calling the SCID for so long, I keep forgetting. It's called the Structured Clinical Interview for the DSM. It's been used for years. And it's a formal, structured, highly reliable way of simply diagnosing major depressive disorders, anxiety disorders, food disorder, eating disorders, all this kind of stuff. So we wanted to see what the difference would be between the associations of diabetes distress with all kinds of stuff and their linkages with PHQ-9 and SCID diagnoses. And what we found was really interesting. Again, 500 patients followed for 18 months. We found that diabetes distress is significantly associated with glycemic control. It was not significantly associated with PHQ-9 and SCID both of them were not significantly associated with A1C. That's both in the type 1 and the type 2 studies. There was significant covariation between diabetes distress and A1C over time. So as the stress went up, so did A1C. As A1C went down, so did distress. It's covariation. It's not causation, but they work together over time. We found no such associations with either the PHQ-9 or the SCID. We found that diabetes distress was significantly associated with diet, medication adherence, and physical activity, not so for the other two measures. And in a recent study that we've just published, interesting finding, the study was an intervention to reduce distress among highly distressed type 2 patients. It was a very successful study. We dramatically reduced distress in this population. It was a distress-focused study. Oh, by the way, the PHQ went down too. And this led us to believe that much of what we think is depression is really nothing more. I don't want to make it light of it, but it's really nothing more than the distress associated with having this chronic, difficult disease. And we need to stop talking about depression because it's got a loaded stigma, scares the dickens out of patients, and for many patients it's culturally inappropriate because it carries all kinds of ramifications we don't really need to go to. Okay? And there's also the risk we start popping medications when they're really not depressed. So where have we gone so far? Let me summarize, because this is a multi-chapter story. We all have problem patients who have major difficulties with disease management. We tend to address disease management by focusing exclusively on behavior and behavior change, education, action planning, all the things in our toolbox. These are necessary interventions, but they're not sufficient for many patients. And I'm suggesting to you that the missing link in the process is the emotional side of diabetes, which I am labeling diabetes distress. And so the question is, where do we go from here? Now I'm in a dilemma, and I'll share the dilemma. You've been sitting here now for 3 hours, and you're thinking, like me, about lunch. So I wanted to provide a way of sharing with you some ideas about how you might use this information to intervene. Because that's what we're here for. We want to gather information and make use of it in clinical practice. That's the idea. So I had two choices. The first choice was I could tell you about it. Boring. The second one is ask you to do it. And so I decided, which is a little risky because it's a big group, I decided on asking you to loosen up a little bit and try simulation. Okay? Willing? You won't embarrass yourself. Nobody has to do anything in public. But what I'm trying to do is to give you an experience where you'll get at least a little bit of the flavor of what addressing the emotional side of diabetes might entail in your clinical practice. So if you're willing, well, even if you're not willing, let's try it anyway. So what I would like you to do is look to your left and look to your right and select the person sitting next to you that you know least well and form a dyad. People tend to sit together that know each other. If you're an odd person out, that's fine. Turn around and try to find somebody next to you. Or if you can't, observe a dyad near you. Okay. Everybody got someone that they consider part of their dyad? Okay. Now what I'd like you to do is this. I'd like you to decide which one of you is the patient and which one of you is the healthcare provider. Don't worry about it because in the second simulation, which will follow, it's only a couple of minutes, you'll switch. Who are the patients? Hands for patients. Okay. All right, patients. Here's your task. What I want you to do, patients, what I'd like you to do, patients, is to think of a healthy change you'd like to make in your life, but you just haven't gotten around to doing it. You haven't made the change, you're thinking about it, it hasn't happened. Now don't pick a huge change, like I'm going to change jobs, I'm going to leave my partner. Pick something manageable, something realistic. And if you can't think of one, make it up. It's okay. All right, so while you're thinking of that, healthcare providers, everybody know who you are? Okay. You are the persuasive healthcare providers. Here's what I want you to do. You're the expert. You know this stuff. You've been doing this for years. Once your patient tells you about the change, I want you to explain why he or she should make that change, give at least 3 specific benefits that would result from making that change, suggest how to make that change, emphasize how important. Get the message? Okay. You have so much to tell these folks. Make sure you talk a lot. Because you know the answer, you have the experience, and you know what won't work. And I'm not being facetious. You are the experts. You really do know from your experience. Make sure your patient knows that. We're going to take 3 minutes. Patient, tell your healthcare provider, persuasive healthcare provider, go to it. Okay. I can see that you healthcare providers are very active. Hey, I can't shut you up. All right. Okay, pause. Press the pause button. Okay, question. Shh. Boy, you guys really get into it, don't you? I was so afraid this was going to bomb, but I got a hunch it worked okay. All right. Okay, patients, What was this like? What was your personal experience of this?
Good suggestions.
Really good.
Hard to do.
That was my next. Any other comments? Overwhelming. Is that something others of you had? Too much. What's the likelihood you would have actually done any of this? Any other comments? Yes.
I have no idea what my issues were, but
Hold that thought, because I'm going to come back to it. Very good point. There was another.
Consideration of the practitioner is really telling me all the things I should do. He's not interested in the reasons why I can't do it.
Did we talk beforehand? Oh, you were going to, I believe you were going to.
From the patient perspective, I thought it was nice to be, to the one asking the tone for the conversation.
Being in the other, yeah, absolutely. Last comment. It doesn't fit? Yeah. Okay, healthcare provider, how hard did you work? Are you exhausted? Imagine doing that for 20 minutes? Right? I'm seeing nods. It takes a lot of work to do this, right? Okay, let's move on. Now what I want you to do is switch. Those of you who are patients are now healthcare providers and vice versa, okay? Now, the new patient, same thing. Can you think of a healthy change you'd like to make in your life, but you just haven't made it yet, you haven't gotten around to it? Again, pick something reasonable, not a big thing, okay? Healthcare provider, we're going to call you the journalist. And here's what I'd like you to do. What I'd like you to do after this person tells you about what the healthcare change is to clearly identify what that behavior change is. Make sure you understand. People say, I want to do this. Get it narrow. Ask the details. Stay neutral and listen. Shut up. It's the hardest thing we do. Healthcare providers talk between 89 and 90% of any clinical encounter. We have a hard time listening and not speaking. And part of it's realistic because we do have a lot to say. We're the experts in lots of ways, and patients want to hear what we have to say. But 80 to 90%, it's awfully hard to have a dialogue. And here's the crucial part for these journalist healthcare providers. Ask for 2 or 3 reasons why they might not want to make this change. Help them identify and label these reasons clearly and repeat and emphasize the feeling tones that you pick up. So you're going to ask for reasons for making the change and the reasons for not making the change. And at the end of the interaction, do not press the patient for a decision. Let the patient decide what to do. So your job is to reflect and get both sides of the argument. Make sense? Don't offer any help or direction. Listen and clarify. Go for it. Okay, conclude your discussion. Wind it down. Okay. Shh. Okay, patients. Okay, patients. What was this like? Hands. Comments? Was that important?
Yeah.
Why?
So I feel like my concerns are actually being heard.
So what? So she heard your concern. Important. So what you were feeling and experiencing was recognized by the other person as important. They were valuing this. They were recognizing who you were and what you were experiencing. Is that fair? I don't want to put words in your mouth, but I will. Okay. Other comments? Yes? And you're worried about that. You're really concerned. You're doing all this stuff, and it's hard to understand why your A1C is so high or your blood sugars are so high. And this is bothering you. Yes? You see what I just did? I used the feeling word, and I reflected it back. Did I hit it close? Okay. That's all I did. Yes, ma'am.
It's also not looking at the disease
As a person, really important. As a valued, active person who's responsible for themselves. Okay, healthcare provider. What was this like? It was? Why? You didn't have to work as hard? Why? Isn't listening hard? By listening, you allowed your patient to tell you what were their very good reasons for not doing what you've been trying to get them to do, but never asked. That's basically the fundamental message. What you help them do is to outline a diabetes emotional tug-of-war. Every patient I have ever worked with wants to be healthy. Every one of them. Well, maybe one or two didn't care, but most patients want to be healthy. They want to participate actively in programs. They want to lose weight. They want to exercise. They want better A1Cs, and they definitely don't want complications. Anybody have a patient who said, yeah, I can't wait till I have my first complication? I mean, it doesn't make sense. Everybody wants that. But on the other hand, they have dramatic fears of failure. They're angry and frustrated with this disease. Many of them feel hopeless that it's not going to matter what they do. It's just not going to make a difference. And so what they end up doing, people used to say, is denying. They're not denying their disease. They're not in denial. They're avoiding. And they have a good reason for avoiding. Because if they pay attention to it and realize what they're doing isn't working, they have no other tools to make it better. And it's really upsetting to them. So avoidance is a positive coping mechanism. It's not something that's bad. Oh, my patient's in denial. That's a really negative way of defining someone, and I'm trying to shift that away into much more understanding context. And they're distrustful of us in many ways for the reasons we talked about, and often very ashamed. So you have this emotional tug-of-war going on internally. And these feelings are not pathological, they're not unexpected, and they certainly are not uncommon. But the feelings and expectations can put brakes on the effectiveness of behavioral interventions. What did the journalists do to make this happen? Look at the list. I'm not going to go over all this because we don't have the time, but you have the slides. This is what you did, and this is what you can do in your practice to help pay attention to the emotional part, the emotional side of diabetes. It's a very different stance than we take as behaviorists. Much more listening, much more clarification, and much more respect for giving the responsibility for this kind of behavior change to these individuals. After all, that's PCMH, isn't it? It's helping patients make the right decisions and providing the resources to make the right decisions for them. And this is an enhancement of the PCMH process. Here are two cartoons that typify it, and someone put their finger on this, the gentleman back here. This is the persuasive healthcare provider. Hager. Anybody read Hager regularly in the column? He goes to the doctor's office, and the doctor says, see the finger sitting out there? And the doctor says, stop overeating, stop drinking, stop staying out late, stop fighting, stop worrying, stop eating sweets, and stop gambling. So Hager goes home, and his wife's standing at the door and says, what did the doctor say? He says, I don't know, I stopped listening. And that's what that gentleman right back there says. We didn't talk either beforehand. Okay. So that's very much the persuasive stance we use. Here's the other one. No one is making you do anything you don't want. I'm just saying we're all headed for Dodge City and we think you should come along. I mean, did you notice the difference in the tone and the strategy and the amount of energy that the healthcare provider has to, okay? All right, I'm overgeneralizing the point, but you get the message. Okay, so here's the rationale. Since we cannot control what we feel, and we often feel more than one way at once, feelings are often outside of our awareness, including those tied to diabetes. But we know that feelings drive behavior. We know that. 50 years of psychological research has shown that consistently. If all this is true, then acknowledging both sides and both sets of feelings publicly helps the patient label what they're feeling, and helps them recognize the impact of feelings on their behavior. The goal is to label and normalize both sides of the emotional tug-of-war, of the diabetes ambivalence, and thus to make public and potentially defuse the distress and ambivalence that prevents many patients from entering into and engaging with programs to improve diabetes management. And that's, from our point of view, the missing link. It's nothing more than a structured way to have a conversation, which is the primary dynamic of all clinical intervention. It's a conversation with your patient, regardless of the content. How do we make this work in clinical care? Well, there are really two ways. There are two methods out there that have been used widely, and I'll just highlight them very quickly for you. One is motivational interviewing. Some of you have heard that. Maybe some of you have been trained in this. It's very popular, requires considerable training and follow-up. It is somewhat unsystematic, and its application in primary care is a little shaky. It was developed for substance abuse, and getting it to work in the confines of patient flow issues in primary care is sometimes tricky because it can be time-consuming. It is not easily protocol-driven, but meta-analyses and a bunch of other studies have shown that it can be effective. There is a new derivative of motivational interview called brief negotiation. I don't know if you ever heard of that, and I'm going as fast as I can. If you Google brief negotiation, you'll find Northern California Kaiser Permanente has an online course, and you might be interested just in going and taking a look at it. The second is a program we developed and have used called AASAP. It works nicely in primary care because it's much more specific. It's an acronym, and it's in your slides, and because of the time, I won't go through all of the details of this, but there's an example of each, and it's basically a way of helping individuals anticipate, acknowledge and label, standardize their feeling, and then make sense of it in the context of diabetes. And this is an evidence-based program as well. We've been teaching diabetes educators how to use this, and we actually were able to reduce no-show rates using this in diabetes education, which is a big, big issue of folks not showing up. And we trained a whole variety of primary care clinicians using this. There are a bunch of take-home messages here. Again, I'm going to skip this because there's one thing I don't want to omit, but I would suggest you take a look at the take-home messages if you get a chance, just to kind of reinforce the fact of how the emotional side of diabetes fits in. And now I want to leave you with one thought. I have been talking about you helping patients with behavior change. I've actually been asking you to undertake behavior change. Right? So what I thought I'd do is leave you with the healthcare provider's tug-of-war, outlining the pros and cons of incorporating the emotional side of diabetes into your practice. because you have a dilemma. On the one hand, you want your patients to be healthy. You want to help them change their behavior. You want to help them improve their ABCs. You want your patients to be happier, to feel successful, to be less frustrated. You want them to feel less demoralized and hopeless. Those are all the good reasons for bringing the emotional side of diabetes into the way you deal or the way you have a clinical conversation with your patients. But there are a lot of very good reasons you shouldn't do it. Really good reasons you shouldn't do it. And you need to weigh them and make a decision for yourself. I hope you'll come to Dodge with us, but it's your choice. You already have an enormous amount of work to do with each of your patients. Enormous. And very limited time. You're already, many of you, overwhelmed with the clinical demands and all the paperwork and all the automated procedures. There may be some fear that if you get into the emotional side of diabetes, you'll be opening up a Pandora's box that will take far too much time and you won't be able to close it down. That's not true, but you may have that fear, and I'll respect that fear. Frankly, you're not comfortable with this stuff. This is not what you're there to do. I'm here to be doing X, Y, and Z, and this is a little too messy. It's not what I like to do. I feel too awkward raising this kind of stuff. I fear not having the right words. Notice all the affective language I'm using. Not only that, if I bring this stuff up, I'm afraid I might upset a patient. So I respect both sides of the healthcare provider's emotional tug-of-war that you're going through. And I'll leave you to make the decision that you think is best. Thank you.
Fantastic talk and very inspirational and makes you think a lot. What I'm going to do, if it's okay, is I'm going to take 2 questions, and then what I'm going to recommend is we decided we're going to break for lunch and sort of have a networking area. I'm going to have the people that are interested in sort of talking to Dr. Fisher and going on to this, discussing a little bit more about this and maybe doing a little workshop, go over on that side of the room. And that's the medication managed track of comorbidities, and we can continue this discussion over here. The rest of the people can go get their lunch and go to these other tracks, which I'll explain in a second, and then this track over here, once you discuss a little bit and the line down a little bit, then you can go for your lunch. So anybody wants to sort of continue what we're talking about with Dr. Fisher, go over on that side over there, and we'll take 2 more questions here.
Yes, ma'am.
Should this conversation be at the beginning when we actually diagnose the patient with diabetes?
The question is, should this conversation be at the beginning when the first experience in after diagnosis?
I asked a question.
Why are you asking the question? What's behind it?
Because I actually did get involved in doing those questions for the patients, and it didn't matter how long they had diabetes. When I asked them, how long have you had diabetes? What was the first thought that came to your mind when the doctor told you had diabetes? And what was the first thing you felt?
Good
Inevitably,
question.
everybody started crying, regardless.
Good for you. Is that okay that the patient cried? Absolutely. Who else is better to cry with than your clinician? Absolutely. My experience is yes, all the time, every interaction. This doesn't take any time. As you're working, you just pay attention to that part. But around particular potentially traumatic periods, absolutely. And it doesn't have to be everybody on the team that does it. There just has to be someone who's paying attention to that part. Good question. That was wow. That must have been an interesting conversation.
Then it showed the outcomes.
Yes, exactly. Any other questions?
Yeah, I have a question. So until recently, that was a very good take-home message today about the diabetes distress versus overdiagnosing patients and stigmatizing them with the depression diagnosis. I mean, so much so that until recently we had papers out saying diapression, diabetes and depression combined, and people coining the term diapression. And the classic teaching, at least in primary care practices, is to do PHQ-2 screening and PHQ-9, and that's how, because the teaching so far has been of a high incidence of depression, patients with comorbid conditions, particularly diabetics. So at this point, from a practical standpoint, what would be an easy way of distinguishing, or we can tell the primary care providers that, hey, this is not a depression, but this is a diabetes distress disorder and put that down in the chart. And I understand a lot of patients are hopeless rather than, and maybe angry with their diagnosis, and too many things to do, and rather than being depressed. So,
Good question.
how do you?
Yes, very good question. I have a lot of problems with screening tools because they're often misapplied. In some data we've just completed, and others have as well, the misdiagnosis using the PHQ is between 50 and 77%. That means that using the PHQ-2 or the full scale, between 50 and 70% of individuals who meet criteria on the PHQ are not clinically depressed. They're not clinically depressed. So I think we have to kind of refocus ourselves around using these screening tools because they're not accurate in this population. They're reflecting the emotional side of diabetes, which is considerable. If you want to use a scale, you can use the Diabetes Distress Scale. It's out there. It's in 18,000 languages. It's used internationally. But it, too, is just a way of having a conversation. It's not some kind of thing that sits up there and says, this is a diagnosis. It's just a tool. That's all that will help you have that conversation. That's a very important point because the confusion of mental health problems with diabetes distress is rampant in this population, in our population of healthcare providers, and we need to separate that out.
Okay, I have a question for you, Dr. Fisher. We talked about, telling people about complications. Dr. Daskovich mentioned you do the retinal screen, teachable moment. I almost get the impression from what you're saying that this might be detrimental to the patient. You want to sort of motivate them, kind of control your diabetes, but is this going to give them distress? They're worried, I'm already starting to go blind here. I'm just hopeless about this,
Good.
So
Yeah.
how do you balance that?
It's a balance. Yeah, I think you just said it very nicely. Of course you have to give these folks the information, and you have to give them the risks and all the other, absolutely. But in your conversation, do it in a way that allows them to feel as if you're sensitive to what several of you said about how they're accepting the information, how it makes them feel, what their thoughts are, what their reactions are, many of which won't come until after they leave. So be prepared at the next visit to bring it up. It's not a matter of either or. It's just paying attention, adding this into the clinical conversation. That's basically all I'm saying. If you don't, you risk them not hearing it, which someone said, just stop listening, right? Or not coming back. How many of you have high rates of no-shows or folks who drop out of care? Don't we all have them? That's what the risk is. But It's a matter of a balance.
Okay, super. Thank you so much, Dr. Fisher. Great.